Welcome to the presentation for Module 7. Module 7 is covering assessment of the endocrine system. Priority concepts that we will be discussing related to all these disorders of the endocrine system are nutrition and elimination. For this presentation, we'll start out discussing diabetes, specifically diabetes type 1 and diabetes type 2. Diabetes is a metabolic disease that results from problems with insulin secretion, insulin action, or both. This slide just kind of defines what insulin is. Insulin is secreted from the endocrine gland, the pancreas. The beta cells of the pancreas are what are required to produce insulin. The main metabolic effects of insulin are to stimulate glucose uptake into the skeletal muscle and heart muscle, and to suppress liver production of glucose and very low density lipoproteins. So basically it keeps glucose levels from becoming too high. It takes the glucose into the cells for metabolism of carbohydrates, proteins, and fats. Movement of glucose into the cells requires the presence of insulin. The lack of insulin in diabetes type 1 allows for a high amount of circulating glucose in the bloodstream. This is why patients who have a diabetes type 1 require insulin given to them. The treatment for it is the administration of insulin. It's typically a subcutaneous injection in order to give them the insulin that they need so that the glucose can be taken into the cells and used for energy. If not, they will end up with high levels of glucose circulating in their cardiovascular system, which can over time lead to chronic complications and some acute complications. Diabetes type 1 is an autoimmune disorder in which the beta cells of the pancreas are destroyed due to this autoimmune disorder. No insulin is produced. That's type 1 diabetes. The key word here being that there's an absence of insulin. So they require insulin replacement. They require insulin injections to prevent a hyperglycemia, which is a high blood glucose level. This is type 1 is only about 10% of all patients who have diabetes, so it's not as prevalent in occurrence. They tend to appear thin and overweight. That's because the glucose cannot be taken into the cells and be used as energy, so they are using other sources of energy, so it's a kind of a state of higher metabolic issues. Diabetes type 2 is a problem resulting from a reduction in the ability of the cells to respond to insulin. So the patient has insulin that the cells cannot respond to it. So that is where the word resistance comes from. In a diabetes type 2 patient, typically a slow onset, present for many years before it's diagnosed. It's usually related to a patient getting older, a patient who is overweight, a patient who has had a high intake of sugary content, high carbohydrate diet, high fat diet, and the sedentary lifestyle can lead to diabetes type 2. Represents about 90% of all people who have diabetes. Typically, this can be prevented. Diabetes type 2 can absolutely be prevented by healthier lifestyles. It's becoming a national healthcare issue that's requiring lots of healthcare dollars to treat it. It can absolutely be prevented by a better, healthier diet and increased activity levels. These are the lab tests that are utilized to initially diagnose a patient with diabetes. Fasting glucose level, usually the patient has to be fasting for more than 8 hours. It's somewhat effective, it's somewhat accurate. It depends on what the patient's intake has been in the past 24 hours. It can have a little bit of effect on it. But it can give us an idea of it as a screening for a patient who has diabetes. The other lab test is something called a glycosylated hemoglobin. Glycosylated hemoglobin, or otherwise known as the A1C, is a good indicator of the average blood glucose levels because it shows the average blood glucose levels during the previous 120 days, the lifespan of a red blood cell. Unlike the fasting blood glucose test, the A1C test results are not altered by eating habits the day before the test. This test is performed at diagnosis in specific intervals to evaluate the treatment plan. A1C testing is recommended at least twice a year in patients who are on treatment, and it's also, like I said, a diagnostic tool. This test measures how much glucose permanently attaches to the hemoglobin molecule. Glucose binds to many proteins, including hemoglobin, through a process called glycosylation. The higher the blood glucose is over time, the more glycosylated hemoglobin becomes. The American Diabetic Association defines A1C levels greater than 6.5% to be diagnostic of diabetes. This slide is a visual for the complication, the acute complication of diabetes, which can be a hyperglycemia, which means that the glucose in the bloodstream is too high. The level of it is way too high. The patient may have these symptoms that are listed on the slide. There are the three P's that are the hallmark of hyperglycemia. Those are polyuria, which means they pee a lot. They're trying to get rid of all that glucose. They're trying to filter it off, which is why the kidneys are, after a long period of time, can be affected by high glucose levels. Polydipsia, which means that they're thirsty. They're trying to drink to try to dilute their blood, to try to dilute that blood sugar out. And then the other thing is that they're hungry, and it's a polyphagia. They're again trying to eat more to dilute the levels of glucose in their body. They will appear dizzy, kind of headachy, weak, tired, have blurry eyesight, feel pretty bad. The main difference between hyperglycemia and hypoglycemia is the three P's. Just want to bring up a treatment for type 2 diabetes mellitus. Oops, that's supposed to be a D. Diabetes mellitus. Some of the main drugs, sulfonylureas, and then we've already talked about metformin. Metformin is usually the first drug that they go to. These are examples of medications used to treat the type 2 diabetes. Sulfonylureas is glipizide is one of them. These trigger the release of insulin from pancreatic beta cells. So that's how they can lower the blood sugar. It can hopefully trigger some more insulin to be released so that it can take the glucose into the cells for use. The sulfonylureas, I spelled that wrong. Sulfon, there's a Y in there. Can cause a hypoglycemia as the most serious complication. Metformin, if you recall, we've talked about this before, that it has a precaution of not being able to be utilized by patients who have kidney failure or kidney malfunction. It works by also increasing insulin secretion by the pancreatic beta cells. It is not known to cause a hypoglycemia, so it's not known to make the blood sugar too low, so it's a fairly safe drug. The only thing is, again, you cannot use it with patients who have a kidney problem. Metformin can cause a lactic acidosis in patients with renal insufficiency. It should not be given to anyone with kidney disease. To prevent kidney damage, the drug should also be withheld for 48 hours before or after using contrast material for a surgical procedure or diagnostic tool. These are the complications of a hyperglycemia. Hyperglycemia, high blood glucose levels over a long period of time, can cause chronic organ damage. It can cause chronic organ damage to the kidneys, to the eyes. It can cause a neuropathy because it damages the nerve endings, which neuropathy is a very painful disorder. It causes numbness and tingling and nerve pain in the peripheral extremities, usually the hands and feet. And this is long-term complications of hyperglycemia. It can lead to dehydration and fluid and electrolyte imbalances. In patients with diabetes type 1, it can cause a diabetic ketoacidosis, which we will talk about at the end here with complications. And then it can also lead to a dehydration in a patient with diabetes type 2, which is another complication of diabetes in a diabetes type 2 patient, which we'll talk about in the next few slides. This is a slide that just shows the signs and symptoms of a patient with hypoglycemia. It is essential that you know the difference between a hyper and a hypoglycemia. Really what happens is if a patient that is a known diabetic or is showing symptoms of diabetes, we're always going to check their blood sugar before we move forward in determining how we need to treat them. We need to determine if it's a hypo or a hyperglycemia because they get treated very differently. Hypoglycemia is usually considered a blood glucose lower than 70. It can be caused by excessive insulin. Some of the oral anti-diabetic meds, such as the glucotrol that I mentioned, the sulfonylureas, can cause a hypoglycemia if the patient takes it and doesn't eat. Insufficient food intake and increased physical activity are other issues that can cause hypoglycemia. The interesting thing is it can mimic signs and symptoms of a stroke. And this is kind of the way to tell the difference between a patient with hyper or hypo. The hypoglycemic patients will get really grumpy and confused and really not act like themselves. And like I said, sometimes it gets confused with somebody who's having a stroke. Whenever somebody presents with stroke symptoms, the first thing they will do is check their blood sugar to determine if possibly it's just a low blood sugar causing these changes in the patient's behavior. If not properly managed, hypoglycemia can lead to brain damage and death. It's important to teach a diabetic patient what these signs and symptoms are so that they can identify it and hopefully treat themselves appropriately before it gets too bad. Most of us know those patients that are diabetic that carry around a little candy with them or a little shot of sugar in case they drop their blood sugar quickly. This slide just basically says the same things that we just talked about in the last slide, just again to look at the signs and symptoms and the causes of hypoglycemia. It's very important to be aware of these because they can be life-threatening situations. And we need to be able to educate our diabetic patients how to recognize these signs and symptoms so that they can be on alert to identify them as well. And carry maybe candy, carry the necessary interventions that they might need to carry with them in order to treat themselves if they find themselves in this situation. These are life-threatening situations that can occur related to a patient who is diabetic. Diabetes ketoacidosis can only occur in a patient who is a type 1 diabetic, and this is the reason why. Diabetic ketoacidosis occurs in people with type 1 diabetes and is most often precipitated by an illness, especially an infection. Patients become acidotic and severely dehydrated. That's the key word that means that it can only occur in a patient with type 1. The reason is because they do not make any insulin of their own. And so if they end up with high amounts of blood sugar circulating and they have no way of taking it into the cells. And we know that when someone is ill already, their blood sugars will tend to increase. So that's why it's precipitated a lot by an illness. So what happens is this patient cannot take any glucose into their cells because they don't have the insulin to do it. So their body will begin to break down fats and proteins in order to establish some form of energy. And we know that we need more energy when we're sick too. So the breakdown of these proteins and fats are ketones. The ketones are acidotic, and we remember all of our homeostasis conversations. We know that our body likes a nice neutral pH. An excessive amount of ketones in the blood due to the breakdown of fats and proteins for energy creates an acidotic state for the body. It's essentially a metabolic acidosis, which is a life-threatening situation. Again, we don't have homeostasis if we have an acidotic environment. Our body is not meant to operate in an acidotic environment. Treatment for this is fluids. They are severely dehydrated because of the high levels of polyuria due to their high blood sugars, typically secondary to an illness. Here's what happens. These diabetics, these type 1 diabetics, they get ill, they don't eat because they're ill. Then they don't take their insulin because they're afraid to take their insulin to bottom out their blood sugar because they're not eating. Here's the problem. Their blood sugars are still going up because they're sick, because of the stress. So they still need insulin. And diabetics type 1 don't have any insulin. So it's a snowball effect. Now, the hyperglycemic, hyperosmolar state occurs in the type 2 diabetes. And is similar to the diabetic ketoacidosis. However, they don't get acidotic. They essentially present very closely to them. They have high blood sugar levels and they are severely dehydrated, but they are not in a metabolic acidotic state. So no acidosis. Emergency treatment for HHS is also fluids. We have to hydrate them. And then we start working on their blood, getting their blood sugar down. But essentially, these are people who are ill, that are severely dehydrated, severely stressed from another illness. And so we need to get that fluid level fixed. We'll give them a liter of fluid. And then slowly start bringing their blood sugar down. We'll start giving them small increments of insulin to kind of slowly bring their blood sugars down and hopefully get that homeostasis maintained. But it's a slow process. These people are in the intensive care unit for treatment because it's an hourly monitoring of their electrolytes, their fluids and electrolytes. This is a visual picture to hopefully kind of help you understand a patient who is in a diabetic ketoacidosis state. Remember, these are your diabetes type 1 patients who have it. Some hallmark signs and symptoms of diabetic ketoacidosis are a fruity breath, and that's because of the ketones. That's how they're different than the HHS patients. So they have that fruity breath smell. You might have heard them say that. The other thing is the Kussmaul respirations. Kussmaul respirations are those really rapid, uneven, labored respirations. That's usually due to the acidosis. And another way that we control our pH of our body is by blowing off CO2. So the patient's body will automatically try to increase respirations in order to get rid the body of the CO2 to try to maintain a better pH level that's less acidotic. The patient in DKA will present with all these signs and symptoms. They will appear severely ill. They will be severely dehydrated. We'll check their labs. All of their fluid and electrolyte levels will be way out of whack. Usually potassium levels are high. We have to monitor that. We have to put them on a monitor for all of that. Labs typically indicative of a DKA are a blood sugar greater than 300, a pH of less than 7.35. Clinical manifestations include dehydration, acidosis, dry mucous membranes, low blood pressure, tachycardic, small respirations, abdominal pain, central nervous system depression. They will appear lethargic. Death occurs in 1% to 10% of these cases with appropriate treatment. So the older they are, too, the more harder it is to treat. Again, got a priority treatment is to get them rehydrated with fluids, and then we start working on the blood sugar. This is just another visual to help you understand the hyperglycemic, hyperosmolar state. Again, this is a diabetic type 2 that gets this. HHS differs from DKA by the relative absence of ketosis and much higher blood glucose levels. They typically have a blood glucose level of greater than 600. Dehydration is the most common cause of HHS. HHS occurs almost exclusively in patients with diabetes type 2. It's usually in older adults who are unaware of that they are a diabetic. This is typically how they get diagnosed sometimes. These are the signs and symptoms of profound hyperglycemia. And we're talking like upwards in the somewhere of 800 to 2,000. Again, with this patient is a priority treatment of correcting the dehydration with IV fluids. After treatment with IV fluids, then soon after that, we'll get the fluids started, and then we'll start trying to manage the blood sugar. And they'll be on an insulin drip in an intensive care unit for this critical state. Again, these are just some signs and symptoms of HHS. Make sure you're aware of them, and that we know that, again, even though it's a little bit different patient because it's a type 2 diabetic, we still correct dehydration and fluids, and then we begin to work on the blood sugar. So just a review of the treatment for diabetes type 2. We've already spoke of a couple of type 2 oral diabetic medications. First line of treatment usually, though, is that diet and exercise. Let's see if we can get those blood sugars down and get this patient healthier by trying to modify some of those risk factors that we can modify. Anti-diabetic medications are not a substitute for dietary modifications. They got to do it along with the medication. It's going to work better. Make sure you understand how to teach a patient to modify their diet. They need to collaborate with a patient, physician, and dietitian all together to find a way to get a nutrition plan that the patient can live with. Dietary guidelines are based on the individual needs of a patient. Carbohydrate intake should be 45% of daily calories. They should have a protein intake of 15 to 20%. Limit total fat intake to 20 to 30%. So that's why they need a nutritionist and a lot of guidance with these. These is kind of hard to keep up with, especially for someone who's not used to watching what they eat. Teach the patient that alcohol must be taken in moderation. And explain how to reinforce how to read labels, reinforce dietary teaching, and follow up frequently. Get them support services. There's lots of community diabetes educators out there that they can collaborate with to make sure that they can get their blood sugars under control. American Diabetic Association is a great resource. They have a website that they can utilize to help them find the information they need. The treatment for a type 1 diabetic is insulin. It's subcutaneously given. So make sure you understand how to give a subcutaneous injection. And make sure that you understand the different types of insulin. They are listed in your book. The important thing to understand that there are different lasting insulins. There's a Lantus insulin, also known as glargine insulin. It's a very long-acting insulin. We've been giving those a lot at nighttime. It's important to understand that this is a long-acting insulin. It has no peak. So typically we do not hold Lantus insulin because it will not drop their blood sugar in a hurry. It's meant to mimic the body's normal insulin like a person with a normal functioning pancreas would have. So it provides a diabetic type 1 patient with a basal supply of insulin. Another insulin that you might see is an aspart insulin or a Lispro insulin. Lispro is a short-acting. Lispro has a peak of 0.5 to 1.5 hours. So basically, that's when it'll get the blood sugar. It's working at its highest. It's working at its highest amount. So if you gave somebody their insulin, then it would peak at about a half hour to an hour after you gave it to them. That's why a lot of you, I don't know how many of you are given insulin in your clinical experiences yet, but you will notice that Lispro insulin is given after the patient orders their meal and when we know it's on its way. And if we can hit it just at the right time, we give their insulin right as the tray's coming, and the patient will take their tray, they'll eat their food, and the insulin should peak about the same time that their blood sugar starts to go up from the food that they've eaten. So by doing it this way, we keep their blood sugar from getting too high. Essentially, what causes the damage, the chronic long-term damage to a patient's organs over time in a diabetic patient, is the fact that they have these big highs and lows. If their blood sugar goes up really high, if it drops really low. If it goes up really high and drops really low, that over time can be very harmful to the patient and their organs. That's why you'll hear a lot of patients who want to just eat a bunch of food and then cover it with a bunch of insulin. It's really not healthy. That's not the way they should go. They need to stop this up and down of their blood sugars. One thing I want you to be aware of is there's a great table in your Silvestri book. Your Silvestri book chapter on your endocrine medications is a great resource for insulin and understanding that there are different types of insulin. They have different peaks. And to understand if you gave a certain type of insulin, when it is going to peak. So when you need to make sure that your patient eats and to monitor them for low blood sugar. This concludes the presentation on diabetes. I look forward to discussing this topic more with you in class.